some of you are probably going, wait, there's some weird things here. And over time, these drugs shift, and a lot of this is based on lobbies. So let's take marijuana, for example, okay? It certainly has medical uses, right? We can talk about its use for analgesia, for nausea, for chemotherapy-induced nausea, for appetite stimulation in HIV/AIDS patients, et cetera. It's been used in medicine for quite a long time. We're obviously probably going to move there in the next 5 to 10 years, certainly nationally, if not statewide soon. What's interesting is it's been labeled as a high addiction potential drug. Actually, you talk to most addictionologists, it's very low on the list. Not to say you can't become addicted to it, I'm not saying that at all. But compared to, heroin or nicotine or alcohol, it's far less, actually. And then let's take the Schedule 4, the benzodiazepines. Low abuse potential. As a pain physician, I can tell you absolutely not. High abuse potential. And we're going to talk about the sister silent epidemic of benzodiazepine-related deaths. Oh, good question. So Ativan, lorazepam, diazepam or Valium, Xanax, alprazolam. So all the drugs you might use for anxiety or for sleep, commonly. And we're going to talk about those in just a bit. So this is my little blurb. If a human took a dose of something and it had a response, that infers that that person has some sort of system that obviously is affected by that substance. So there's got to be a reason for it. So if humans throughout history have been grabbing the poppy or whatever, and they derive some benefit, obviously there must be some sort of inherent system. We're not eating daffodils on a regular basis because there's not much of an effect other than maybe getting nauseous, right? But we might have grabbed willow bark and used that and noticed, oh, it helps my pain, and I noticed that I bleed a little bit more easily, and willow bark, aspirin. So obviously, we have been trying substances in nature and medicalizing them, and I'm going to talk about that in just a second. And this concept is very old. This gentleman, Paracelsus, 500 years ago, the father of toxicology, in his Latin there, dosis facit venenum, which translates to the dose makes the poison. It's not the drug. We're going to talk about a lot of things like, oh, they're bad. Not necessarily. It's really the dose that matters, because I could theoretically kill someone with water. I could kill someone with air. But I could heal someone with alcohol. I could heal someone with heroin, believe it or not. So it's really not just the drug itself, but it's how it's used and the dose. So here are some examples from nature. If you can recognize these, I'm very proud of you. You deserve a botany degree. So in the upper left-hand corner is cocaine. And you can see below is peyote, then grain alcohol, or the mash there. You saw the papaverum somniferum, and below is marijuana. And people will classify these groups of drugs as stimulants or uppers, hallucinogenics, sedatives and downers, opioids and cannabinoids. And, well, look, we use all of these medically. We use cocaine as a local anesthetic. We don't use methamphetamine, but we'll use methylphenidate for attention and wakefulness. We'll use ketamine for anesthesia. People have used LSD or are studying LSD for post-traumatic stress disorder. Ketamine is being studied for depression. Clearly, barbiturates and benzodiazepines have been used in anesthesia, for anxiety, for sedation. Morphine, obviously, all these things, analgesia, diarrhea, and cough. Marijuana, as I mentioned, for nausea, appetite, and analgesia. So all of these substances, you can either say we use them medically or vilify them and say they're this illegal drug. There's usually two sides to the coin. So that whole DEA schedule is a bit arbitrary, wouldn't you agree? I mean, we can take almost any one of those narcotics in Schedule 1 and use them medically. For example, heroin is used in the United Kingdom medically, okay, not just as an illicit substance.